afternoon, everyone. My name is Ioana Angurano, and I'm the Community Health and Prevention Analyst at ASCO. I'm honored to welcome you to this webinar on behalf of the CDC and to be joined by Suzanne Hurley, the Dissemination Team Lead at the CDC for the PRC program, to discuss community-based research the prevention research centers have developed to reduce health disparities and improve community clinical linkages.
Hello, everyone. This is Suzanne. This webinar, Engaging Community Health Workers to Reduce Chronic Disease and Promote Community Clinical Linkages, is the first of a three-part series with ASCO, highlighting the research and tools. We are in the process of planning the next webinar, which will be related to nutrition and is expected to be held in March. We'd very much like to thank ASCO for their efforts showcasing the work of the PRCs and for organizing these webinars. Ioana?
Before we get started, I would like to provide an overview of the logistics for this afternoon's webinar. This webinar is currently being recorded, and a link to the recording and webinar slides will be sent to you via email and posted on the ASCO website. Following each presentation, participants will have the opportunity to ask PRC researchers questions. In addition, there will be a 10-minute panel discussion at the end of the webinar, providing presenters and participants the opportunity to discuss ways to engage PRCs. We invite you to participate by typing your questions into the on-screen chat box at any time during this webinar. I would like to start the webinar with a quick video that provides an overview of what the prevention research centers are. In 1984, Congress passed an amendment developing a network of academic centers to conduct community-based research because public health leaders recognized the importance of a strong link between public health research and practice. The Prevention Research Centers, known as the PRC program, consist of 26 public health universities or schools of medicine that conduct community-engaged research. Each PRC conducts a core research project over 5 years that addresses behavioral and environmental factors within a community that is experiencing health disparities. Each PRC designs, tests, and implements a health promotion and disease prevention program. PRCs engage a variety of partners, including community stakeholders, federally qualified health centers, local and state public health departments, clinics, schools, and primary care providers. Currently, 14 of the 26 PRC programs use community health workers to provide health education and serve as a link between community and clinical services. In addition to core research projects, PRCs are hubs for research, conducting hundreds of projects over a 5-year cycle with other funding. Their primary areas of research include smoking and substance abuse, cancer, cardiovascular disease, injury prevention, sexual health, obesity, nutrition, and physical activity. PRC centers also work within 7 thematic research networks in which several PRCs collaborate on a specific research topic in multiple settings. For example, the Cancer Prevention and Control Research Network, known as CPCRN, consists of 8 PRCs who work with public health partners to disseminate evidence-based cancer control programs. PRC research can be translated into tools and public health programs. Since 2009, the PRC network has conducted 1,200 projects, published over 3,000 publications, and trained over 56,000 public health professionals. The PRCs produce evidence-based programs, evaluation tools, public health guides, and trainings. Here's a sample of work that has been translated. The University of Washington PRC developed Enhanced Fitness, an exercise program that improves the quality of life of older adults. Enhanced Fitness has been proven to improve the strength, balance, and flexibility of over 60,000 participants and has been implemented at over 600 locations in 39 states. CATCH is a health program originally developed by the University of Texas at Houston PRC to increase the nutrition and physical activity of preschool to 8th grade children. Since 1991, over 10,000 schools have implemented this program. The PRLS Toolkit is a treatment program developed to reduce the symptoms of depression of seniors and adults with epilepsy through home-based counseling. PRLS has been implemented at over 50 sites in 18 states. So how can you partner with PRCs? PRCs often engage community stakeholders, clinics, and public health agencies in the implementation of research projects. PRCs offer technical assistance through evaluation, program development, and surveillance support. Some PRCs also engage partners and health officials as members of their advisory board. The 26 PRC academic centers provide online or in-person public health training. For information about PRC academic centers, tools, and training, please visit www.cdc.gov/PRC and individual PRC websites. Please keep an eye out for a forthcoming AGPM supplement on the PRC program expected this March. Our first speaker is Maya Ingram from the University of Arizona PRC. Maya Ingram has a master's in public health and is the co-director of the Arizona Prevention Research Center at the University of Arizona College of Public Health. Over the past 20 years, Ms. Ingram and her colleagues at the Arizona PRC have partnered with community health workers in health centers and grassroots agencies in rural, urban, and U.S.-Mexico border communities to develop and evaluate community health worker programs addressing diabetes prevention and control, health promotion, mental health, and most recently, hearing loss. Research interests focus on community health workers as community change agents. Ms. Ingram led the evaluation of the National Women's Health Leadership Institute, a program developed and implemented by Mariposa Community Health Center in Nogales, Arizona. Ms. Ingram is also involved in a statewide effort to create a voluntary certification system. The current Arizona PRC research focuses on using the community health worker model to link community programs and clinical care. Ms. Ingram?
Thank you. Thank you very much for the introduction. And I'm honored to be here presenting with everyone today. To be the first presenter is quite exciting. And also it's a great privilege to be able to connect with so many local health officers and departments around the country. So I'm really pleased for this opportunity. As you see on my presentation, it's not only me presenting, but Abby Lohr is responsible for some of those slides. She is the senior research center here at research specialist here at the PRC in Arizona, and she's overseeing our current research project, which I'm going to talk about. What I'd like to do in my short amount of time is to give you an overview of our PRC, and then just so you get a sense of how you might connect with your local PRC, to give you some examples of how we're currently collaborating with the Arizona Department of Health Services and other health departments locally. Give an overview of some of the curricula that we have available on our website, and then to just give you an overview of our research that focuses on community clinical linkages in care using the community health worker workforce. So we were originally funded in 1998, and so we've been in 4 research cycles, each one having a research focus. And you can see on the bottom of the slide that little preparatory outreach office there. We actually had our own community health workers hired by the Prevention Research Center when we started, and those are those 2 community health workers who still work with us, and then these other pictures are from more recent projects. We also have a community action board that's made up of representatives from organizations from the 4 border counties in Arizona. Those are federally qualified health centers, county health departments, area health education centers, community organizations, the Arizona Community Health Outreach Worker Association, and they are all charged with guiding us in our research questions and in our other activities. So giving you an idea for some of the work that we've done with health departments, I'm focusing on the Arizona Department of Health Services because we've just had a very mutually beneficial collaboration over the last few years, specifically with the Division of Preventive Services. Right now, the AZPRC is conducting an internal evaluation of the preventive services, looking across their 4 bureaus and how the 1305 grant has contributed to internal synergy and coordination across programs to help guide them in their activities. And in turn, they've taken that model and are sharing that with local health departments through their what they're calling their integrated intergovernmental agreement, which is taking the categorical programs and creating one contract. And so we're working together to look at logic models that function across all of those counties, as well as an evaluation that can really look at movement as a state towards prevention goals as opposed to county by county. So that's very exciting. We also do some localized evaluation with ADHS and community members. Currently we're helping with the evaluation of a community health worker paramedicine program located in Santa Cruz County with a couple of local partners, the Rio Rico Fire Department and the Mariposa Community Health Center. So that kind of gives you an idea of the evaluation scope of what we can work on together. We do trainings, and many of those are facilitated or brought together by the state health department around logic models. Abby recently did a webinar on logic models for county health departments, and we've also done some work more recently around policy evaluation. So I wanted to take just a moment and highlight, you mentioned it in the introduction, but the Community Health Worker Workforce Coalition is a contract that the AZPRC has from the ADHS through their 1305 funding, and the goal of that contract is to bring stakeholders together to address the sustainability of the community health worker workforce in the state of Arizona. And we've been around, I think, for 3 years doing that collaborative effort also with the Arizona Community Health Worker Association. So we have over 100 stakeholders at the table now, and we've made huge strides in terms of identifying the scope of practice for community health workers in our state and the core competencies, and looking at avenues for reimbursement of the workforce that can be more sustainable. And as mentioned, we're working collaboratively on developing a way for community health workers to become voluntarily certified in our state, so that's very exciting. You noticed in that presentation at the beginning the video of all of the programs that our partner PRCs have developed that are being used nationally. And indeed, one of our mandates as a PRC is to create evidence-based programming and to make sure that it is disseminated. And I would just want to underscore that local and state health departments are extremely important in that relationship. And so we really look to them to learn about our programs and help us disseminate them. So that's another really important relationship that we have. So my next couple of slides just sort of give a short overview of the curricula that the Arizona PRC has developed with and for community health workers around the prevention and control of chronic disease. And these curricula were developed in collaboration with our community partners that are also Community Action Board members. So the bottom two on this particular slide are both now on the CDC website. They're recognized as evidence-based, and all of our curricula have some level of information accompanying them that you can access. All of these curricula are available online in Spanish and English, so I encourage you to come and check them out. And then if you'd like some additional information on them, you can certainly contact us. The last couple programs on here, the Community Health Manual was actually developed by a community-based organization in Yuma, and we just kind of helped them create a manual out of it. And the Vir Mejor is another program of Mariposa Community Health Center that we sort of, all we did was really package it for other communities to use. So we're excited to have that available to you. So I just wanted to spend the remainder of my time talking about our research project, which is about creating community clinical linkages using the CHW, the Community Health Worker Workforce. And our research project was a little bit complicated. We had a hard time describing it to other people, so hopefully I'll do a good job here today. But basically we had 2 phases. And in the first phase, we collaborated with 3 federally qualified health centers to identify the best practices for community health workers in a clinical versus a community setting. The curricula that I shared with you were all curricula that were developed in collaboration with community organizations and were designed to be implemented in the community, but we didn't feel we knew which of those were most effective within a clinical setting, which has a very different culture, a very different environment for delivering programs. So we felt it was important to see what they were doing and make some recommendations. So the results that you see on the slides here are basically things that we observed in the field and also looked at in the literature to see which of those are effective. So we recently, we have an article coming on about that in the Journal of Ambulatory Care, and Abby is working on creating infographics that will also be on our website that are kind of a how-to guide for these recommendations that we have from the first phase of our research. So hopefully those will be available soon. The second phase of our research is really to take those clinical practices, because all of the clinics that we work with have community health workers currently on staff, and create a linkage into the community using community health workers that are working in county health departments. So for us, the definition of community clinical linkages are collaborations between healthcare practitioners, clinical settings, and programs in the community, both working to improve the health of the people in the communities in which they live. So that was our working definition. And our actual model is to take clinic community health workers who are identifying patients in their settings that have specific needs, and they refer to community health workers in the county, and those two continuously communicate and collaborate to provide services. The county CHWs are the ones that are receiving the funding for our specific research, and in that context, they are providing evidence-based programs which support chronic disease prevention and management. And those programs might be the ones that come from the PRC, or they might be ones that they're offering already, such as the chronic disease self-management program developed in Stanford, so things that the tools that the community is already using. We also thought it was very important to try to house this community health worker in a county health department because you not only have access to all of the health-related services, but you also have a much broader range of services that can address the needs of clients. And so therefore, that person is also able to advocate for access to social determinant services. And finally, we have an overlay of simple strategies for stress reduction around chronic disease management. And that came from the recognition over the years that emotional wellness is a big part of chronic disease management, and that indeed community health workers are doing a tremendous amount related to social support for living with a chronic disease and managing a chronic disease, but it has not been well documented. And so our effort here is to document specific intervention and the outcomes of those activities. So that in a super nutshell is our research project. We're just starting the intervention phase, hopefully in the next couple of months. So just in closing, I wanted to tell you a little bit about our partners. So the clinic, again, is our three SQHCs. The county health department in Yuma will be providing the programs. The Arizona Community Health Outreach Worker Association is going to be responsible for providing the training and ongoing technical assistance to our partners in employing the community health worker model. And the Arizona Prevention Research Center is evaluating the model. And our goal ultimately is to have a scalable, sustainable clinical community linkage model to improve chronic disease emotional wellness. I want to point out that, yes, it's true, my slide does have the word ASK on it, and that's an error on my part. I should have a period after that. My 14-year-old son pointed that out to me when I was practicing this morning and couldn't do anything about it. So if you have a 14-year-old son, I definitely recommend that you show it to him prior to actually finalizing your presentation. Okay, so I believe that's all the slides that I have. I do want to thank the CDC for their ongoing funding and technical assistance to the Prevention Center program, and also to our Community Action Board members who are really the drivers around deciding what we research and really do the research projects with us. And I'd love to answer any questions if anybody has any questions relating to my presentation. I think I have a couple minutes.
Thank you, Ms. Ingram, for your presentation. We do have a couple of questions. So first, how do you determine who needs or would benefit from community health worker services?
That's a really good question, and we toss that around a lot. We decided ultimately that the health center would be deciding which patients need the services the most. We wanted to make sure that we did not duplicate the services that were currently being offered by the clinics. And so, for instance, in one place, it's really anyone who's identified at risk in the electronic medical record. Those people are available for services because we know in that geographical area that the clinic is not providing the classes and the things that they're able to do in other places. So that was really just availability of that specific clinical population, and that they have risk for chronic disease. I should mention that our evaluation involves the electronic medical record and tracking those people over time. So that's both identifying and then following the participants in our study. So they really will remain in the clinical home. We're not like passing them on and referring. We're really maintaining that connection between the clinic and the community.
Great, thank you. And just one more question. What do you consider to be the difference between a clinical community health worker and a patient navigator?
Well, I think that's a good question too, and patient navigation is certainly one of the activities that a community health worker in a clinical setting might be taking on. For the Arizona Community Health Worker Association, we've identified a really important characteristic of a community health worker being that they are from or a trusted member of the community served. So that's something that a patient navigator can either have that characteristic and quality or not. They also sort of have a broad spectrum of practices that they're employing that have to do with creating a trusted relationship in the community. My understanding of patient navigation is it really came out of the cancer care model and is really to help people get through the services they need to care for their disease. And that's a very important and specific role, and community health workers might be doing that, and they might be doing other things under their scope within the particular setting that they work in.
Our second speaker is Jennifer Lehman from the University of North Carolina at Chapel Hill. Jennifer Lehman has a doctorate in public health and is an associate professor in the School of Nursing in the Prevention Research Center at the University of North Carolina at Chapel Hill. Dr. Lehman's research focuses on translating, disseminating, and implementing evidence-based prevention interventions that target change at the levels of policy, systems, and environment.
Good afternoon. I'm going to tell you about our Prevention Research Center's core project, which uses community health workers to link clinical and community services to prevent cardiovascular disease. Our Prevention Research Center is called the Center for Health Promotion and Disease Prevention and is located at the University of North Carolina at Chapel Hill. It's directed by Alice Ammerman, and the other three individuals listed here all have provided leadership to the core project that I'm going to be talking about, and include Samuel Sykert, Carmen Samuel Hodge, and myself. So before I talk about the purpose and the aims, I just want to say a little bit about how we chose to focus on community health workers. Alice Ammerman, our director, consulted with the folks in our state public health department and asked them where they would like us to focus with our renewal, and they asked that we focus on community health workers. And so that's the starting point for the development of our core project, and we continue to collaborate with the state on a task force that's working on defining the community health worker role for North Carolina. And so we are serving as a small laboratory to help inform what's happening at the state level. The purpose of our project is to develop and test a multi-component strategy to integrate community health workers within a clinic and public health collaboration with the goal of preventing cardiovascular disease. We are doing this in 2 different counties in North Carolina. During the first 3 years of the project, we're doing it in 1 county, and then starting in the third year, we're replicating it in a 2nd county. The aims are to first conduct community-engaged formative research to design the strategy in partnership with community partners, and then to assess the strategy's implementation and effectiveness with the overall goal of developing a dissemination plan for taking the strategy to scale. So within the county that I'm going to be talking to you about, which is Hertford County, our primary partners are ourselves, and then the Roanoke-Chowan Community Health Center, which is a federally qualified health center, and the Hertford County Public Health Authority. Hertford County is rural. It's predominantly African American. 26% of the population lives below the poverty level. And as a whole, the county ranks 95th among North Carolina's 100 counties for health behaviors, with high rates of smoking, adult obesity, and physical inactivity. We are using a community health worker model where we identify lay members of the community and train them to serve as community health workers, and they are employed full-time with benefits. One of them is employed by the federally qualified health center and the other by the health department through a subcontract from our Prevention Research Center. So the rationale for using community health workers in a linking role is that clinics are good at identifying and treating at-risk patients. However, they only identify those who seek care, and they typically lack the capacity to spend much time working on behavior change. Public health and other community services may have greater reach to underserved populations and also greater expertise and resources and capacity for supporting behavior change. So the intervention, the core of our CHW is a behavior change intervention that they deliver. This intervention was developed over many years by faculty within our Prevention Research Center, including Tom Kaiserling and Alice Ammerman and others. We are now in this project adapting it for use by community health workers who are working in a linking role. The intervention includes 4 monthly in-person visits and 3 phone calls focused on providing tailored education counseling to change behaviors in 4 areas: healthy eating, physical activity, tobacco use, and medication adherence. The CHW can't cover all the sessions in the participant manual, and each participant is given a manual that has been tailored to the county and to the population. And so the CHW works with participants to identify the behavior change they're most ready and enthusiastic about starting with. So just to say a little bit more about what's included in this health behavior change intervention, the healthy eating modules take a Southern Mediterranean diet approach, and you can see the 4 sessions that are covered. And the physical activity modules start with walking and then build on walking with other types and approaches to physical activity. Each session starts with the participant manual, which has brief information about each of the behavior changes. In this case, you're looking at a shortened version of the session on eating healthy fats as opposed to unhealthy fats. And so first, the CHW covers simple information about the behavior change. Then they work with the participant to establish 1 or 2 goals for the next month. And then the third step is to make referrals to community and clinical resources that can support the participant in making those behavior changes. On the next visit, they start by reviewing goals and the individual success at completing the referrals, and then brainstorm ways to overcome any obstacles that were encountered in completing those referrals. So to support the community health worker in this linking role, during our first year when we did our formative work in the community, we identified 73 resources in the community, and you can see the list of the kinds of resources we identified. And then we created both a hard copy and online version of the resource directory to support the community health workers' referral function. So just as a summary of where we're at, in year 1, in County 1, we did our formative work to develop our partnerships, do our formative work, and refine the strategy for that county. And in years 2 and 3, we are currently implementing the strategy and assessing its effectiveness and implementation, and starting the work to do formative work in the second county, where we will then implement the intervention for the final 2 years of the project. So I want to say just a little bit about the other kinds of resources that our Prevention Research Center offers to state and local health departments. We are available to work with you on developing your internal evaluation capacity, to provide training for staff in evidence-based decision making, and we have in fact partnered in providing trainings throughout the state. We're willing to work with you on developing communication plans. We've created a platform on an internet site where we disseminate North Carolina developed prevention interventions and resources called research4nc.org. We are available to participate on your advisory committees, and we are very grateful for the participation of state and local health on our PRCs advisory committee. And we're always looking for opportunities for strategic partnerships and networking connections to enhance public health research and also applied public health practice and also applied research. I want to say a little bit about an initiative that's fairly new to us, but I think is exciting, and it's with the Granville-Vance Health Department, which has created what it's calling an academic public health department, where a faculty member from our Prevention Research Center spends 1 to 2 days a week at the Public Health Department, working alongside other folks in the Health Department, providing technical advice to build internal evaluation capacity, training, support for implementing evidence-based interventions, assists with grant writing, and they've been very successful in that area, provides linkages between the Health Department and resources on campus and in the Prevention Research Center, and also provides faculty with access to resources for community-engaged research in rural settings. All right. Questions?
Hi, thank you so much for your presentation, Dr. Lehman. Do the community health workers give out the resource guide to participants or use them for their own use?
Each participant is given a manual, a participant manual, which includes all the information for the actual intervention. The resource guide is not given to the participants. Specific referrals are made, but it's a pretty big document with 73 different resources. So we are not handing that out.
Can you expand on the approach you are using to address incorporating community health workers into state or federal policy?
So that is the State Health Department has set up a task force that has been meeting to, so that folks who are working with CHWs can collaborate to identify competencies, certification requirements, training requirements. But I don't know what specific policy changes are being advocated for at this time.
How do you recruit your community health workers?
So we have really given ownership of the community health workers to the two sites where they're located, which is the Health Department and the FQHC. So they each, we collaboratively created position descriptions and position requirements, and then they posted the positions and hired them through their standard recruitment and hiring processes.
Are you using any trained wellness coaches to help create the behavior changes you are seeking? So I know that the FQHC has wellness coaches, people that fill that kind of a role that an individual could be referred to, but we are primarily relying on the community health workers, who we do train and provide with a pretty protocolized curriculum to deliver that service. We have time for just one more question. How are referrals to the community health workers integrated into the clinical workflow at the SQHCs?
So that's a great question. That's something we really worked on a lot in our first year, is to figure out the best way to do that. And it's an ongoing process of raising the awareness of the provider, of the availability of the CHW. We also went through lists of clinic patients and highlighted the top priority ones based on their CVD risk, and provided those to the clinics so that they could flag the charts to help cue the providers to make the referrals.
Great, thank you so much, Dr. Lehman. Our final speaker is Nadia Islam from the New York University School of Medicine. Nadia Islam has a PhD and is a medical sociologist in the Department of Population Health at the New York University School of Medicine. Her research focuses on developing culturally relevant community clinical linkage models to reduce cardiovascular disease and diabetes disparities within Asian American and immigrant communities. She's the Deputy Director at the NYU Center for the Study of Asian American Health, a NIH-funded P60 National Research Center of Excellence dedicated to reducing health disparities facing Asian American communities. Dr. Islam is also Research Director at the NYU PRC and Principal Investigator of a CDC-funded Racial and Ethnic Approaches to Community Health Program project. She also serves as a Principal Investigator on several NIH and CDC-funded initiatives evaluating the impact of community health worker interventions on chronic disease management and prevention in diverse populations. Dr. Islam's work has been featured in the American Journal of Public Health, diabetes care, and numerous other peer-reviewed journals. Dr. Islam?
Thank you. Good afternoon to everyone. I'm pleased to be sharing our work today on advancing Million Hearts goals through integrated community health worker and provider models. As I already mentioned, I'm the research director and lead the core research project of the NYU CUNY Prevention Research Center, PRC. We've been funded for 2 cycles, so this is our second funding cycle from 2014 to 2019. Our PRC is a public-private partnership between NYU School of Medicine and CUNY School of Public Health with an overall mission of developing and evaluating effective and sustainable community clinical linkage models for chronic disease prevention in urban areas. Our core funded project through the PRC is Project Impact, which I'll be discussing today. We also lead the evaluation for an externally funded Department of Health-led project called the Harlem Health Advocacy Partners. And I'll highlight this again at the end of my talk as an example of how health departments can engage PRCs in their work. So I'll start off with a little bit of background. So there's a growing emphasis on models that effectively link communities to healthcare systems to improve cardiovascular disease disparities and outcomes. So as all of you on the webinar are very familiar with, Million Hearts is a CDC and CMS initiative that aims to prevent 1 million heart attacks and strokes by 2017. A cornerstone of this initiative is the implementation and dissemination of innovative community clinical linkage models that are evidence-based to improve blood pressure control. Million Hearts aims to foster partnerships with diverse stakeholders spanning from clinical partners, community partners, and industry partners such as payer organizations and others. The particular focus of our work at the NYU CUNY PRC in Million Hearts implementation is small primary care practice settings serving immigrant communities. And this is for good reason. Both nationally and in New York City, there's a large proportion of practices that are run by single or 2 to 3 physicians. And in New York City, small primary care practices largely serve immigrant and minority communities. The community that we're engaging in our study are South Asian Americans. Asian Americans as a whole are the fastest growing minority group in the United States. And within them, South Asian subgroups, including immigrants from India, Bangladesh, and Pakistan, are one of the fastest growing subgroups. South Asians have a high burden of cardiovascular disease, and our own research, as well as research both nationally and from other immigrant communities, has found South Asians develop hypertension at younger ages and at lower levels of BMI, yet there are very few culturally tailored initiatives that are reaching this population. So today I'm going to be telling you about Project Impact. Impact stands for Implementing Million Hearts for Provider and Community Transformation. Our goal with the study was really to test the integration of 2 evidence-based strategies to improve hypertension control in small primary care practice settings that are serving largely South Asian patient populations. So as I mentioned, our intervention has 2 components. The first is a HIT intervention that includes training practices to optimize the use of their electronic health record through the use of registries to identify uncontrolled hypertensive patients and the use of alerts and order sets to better manage their hypertensive patients within the context of a visit. The second component of the project is the integration of community health workers into the clinical team at the primary care practice sites. So in our intervention, CHWs are trained lay health leaders that share common life experiences with the communities that they serve. In Impact, CHWs are responsible for leading group and one-on-one coaching of patients designed to improve hypertension management, connect patients to resources, and enhance self-efficacy for disease management and health promotion. We have several important partners in this project that are really critical to the implementation process, and in our minds, eventually essential for sustainability and scalability of the project. So one of our core partners is Health First, which is New York City's largest Medicaid payer organization, representing almost 1 million members in New York City. They have a particularly strong penetration in minority communities and with small primary care practice settings. Health First has really a multi-component role in our study. They are working with us to identify practices to enroll into the study. We're working with them on data acquisition to evaluate the effectiveness of our study through claims data, and they're really key in our sustainability strategy. So if we can demonstrate that the model that we're proposing works, it provides incentives for Health First and other payer organizations to take on these types of initiatives in small practice settings. Another core partner on our project is IPRO, which is New York State's QI organization. They particularly work with medical practices in building their capacity to achieve meaningful use and PCMH status, and we've designed the EHR component of our intervention to align with these types of incentive programs. And then finally, we have an EHR consultant that is really a super user in several of our EHR platforms that we're working across. So just a few notes on the design of our study. We're enrolling 6 primary care practices into the study and using a modified stepped wedge design. At all of the sites, the EHR component of our intervention is implemented first, and we implement that over the course of 1 year. After a 12-month period, the CHW component of the intervention is introduced into each of the practices. Our primary outcome of interest is blood pressure control at the last measured visit among individual patients, and our secondary outcome is really understanding the aggregate proportion of patients with diagnosis of controlled hypertension in the last 6 months of observation. The results that I'm going to share with you today are very much focused on the implementation process of the EHR component of our intervention, but I'll also discuss throughout how engagement of community health workers was essential in this process as well. And really the first part of our process was recruitment of sites into the study. We very much use a multi-pronged approach for site identification. So as you can imagine, there was no magic list of practices that existed of small primary care practices serving this population. We also didn't have, for example, an independent physician association in the South Asian community that we could tap into. Instead, we partnered with Health First, the payer organization, to use a geographic targeting method of targeting high-density South Asian neighborhoods. From this, we generated a list of 107 practices in these neighborhoods. And then we used a surname list to narrow down that 107 practices to about 40 practices. With those 40 practices, we completed a practice assessment with 29 sites to really characterize the patient population, practice staff makeup, their use of electronic health record, their use of health coaching and other lay health models, as well as referral strategies. Even the process of completing the practice assessment was very much multi-pronged and included conducting outreach letters from Health First, phone calls and follow-up by our community health workers who are part of our study team, and follow-up visits from the study team, including myself, community health workers, as well as the research team. To date, we've enrolled 14 practices into our study. And this next slide just provides an overview of the overall workflow of our project, which, as I described, includes outreaching to the practices, conducting the practice assessment, signing a memorandum of understanding with the practices to enroll into the project, and establishing a protocol with them for extracting data on an ongoing basis. And then the first part of the intervention is the EHR component. From our practice survey, we found these small primary care practices to be very low resource settings, low resources in many regards, from staffing to time to money. So the EHR intervention was very much designed to be simple and as sort of non-resource intensive as possible. And it basically was streamlined to these 3 components. We engage in a fairly short training period over the course of 3 days with each of the practices. And that includes the first day where we conduct a workflow analysis and baseline assessment. On day 2, we train the practices on the use of registries, meaningful use, and PCMH. And on day 3, we train the practices on order sets and alerts. We follow up that initial 3 days of training with approximately 5 technical assistance sessions that are offered over the course of 6 months, and then we engage in regular data pulls with each of the practices. So I'm going to share some of the baseline results from the sites that we've enrolled into the study so far. What our practice assessment results demonstrate are that the practices we're working with are serving a very high-need population, and they also point out some of the constraints that practices face. So as you can see, there are very few staff. These are quite literally kind of mom-and-pop type of shops. They're fairly new to the use of electronic health record. As you can see, about 30% of patients at the practices on average have hypertension. And if you look at this last orange box on the right-hand side, you may be wondering, since our primary outcome is uncontrolled hypertension, why I have not shared that data. And this is part of the process of implementing applied research studies. We came to find very early on that blood pressure data at the individual level was not available through the Health First claims data warehouse, and even pulling it directly from the electronic health record is quite complicated. So we have a multi-part bifurcated data acquisition strategy, and we're actually having to work across several EHR vendors and have found that pulling controlled and uncontrolled status varies across the system. So in short, that last orange square is sort of in progress, and I'll kind of talk about that again in the challenges section. Our early experience has shown us that this model is feasible and practical and accounts for time constraints of practices. On average, we're offering approximately 4 hours of training over that 3-day period, and on average, approximately 4 TA sessions. We've been collecting ongoing kind of in-depth qualitative information from the practices, and you can see in purple a quote from one of the practices in terms of the benefits of participation. But of course, like any applied public health project, there are various challenges that we're having to overcome, and these are in regards to the practice context, community context, and the partner context. From the practice context, as I've explained, these are very low resource settings, and the practices have sort of a very low baseline knowledge of how to use the electronic health record. The plus side of that is that the type of program that we're offering is highly desirable and needed. In terms of the community context, these practices are seeing a largely immigrant population, and so the context of immigrants' lives transfers over to the clinical setting. Long working hours for immigrants means these practices have very long hours. Many are open 7 days a week. There's a culture of allowing kind of walk-in hours for patients, no appointments. And they're also dealing with a very diverse and limited English proficient population, so counseling and health coaching needs are challenging. And challenges with the partner context, specifically payers and vendors, have emerged. So as I alluded to, we found that from the payer side, the utility of claims data does not always meet the needs of the study or meet the needs of the question that we're trying to answer, which is how do we improve uncontrolled hypertension. And it's required the kind of capacity building of the payer organization we're working with. At the same time, we found vendor engagement is critical. We really found through this that EHR vendors, even those that really are sort of have population health management baked into their systems, are not necessarily designed to meet the needs of small primary care practices who really require simple methods without additional add-on software that are often kind of pricey and unaffordable to these settings. So what we found is that practice engagement is complex, but in-person contact is critical, and practices are hungry for resources. A real selling point of our intervention is the multi-pronged nature of the project. CHWs are part of our engagement team from the beginning, and what that's allowed us to do is we've been able to paint a complete picture for practices of how something like running a registry list to identify your hypertensive patients can be linked to CHW coaching efforts. In terms of programmatic needs, we found that we really have to balance flexibility with the need for protocols, workflow analysis, and training manuals. And it's these components that we've created that we think are replicable and potentially scalable parts of our program. In terms of HIT considerations, we have developed a model that is kind of agnostic of EHR platform. We're at least working across 2 EHR systems, but we're also learning that engagement with the vendors is crucial. And this figure on the right kind of outlines what we believe is a replicable model for practice engagement and training capacity building, specifically with small primary care practices. We have developed many projects that can be disseminated across payer, health department, and other organizations, and these range from patient level to practice level, such as training manuals, curriculum. And I also just want to note that we're informing policy considerations. So I'd like to highlight this policy brief that our PRC recently put together on the integration of community health workers into primary care systems. This actually compiles best practices from several sites across the country that are integrating CHWs into healthcare systems, and then has some special considerations for New York State. The link on the PowerPoint slide will take you directly to that report. So the CHW component of Project Impact is actually going to be launched in a little more than a month from now, in March 2017. And we have developed this protocol that's really linked to the first part of our intervention, which is optimizing use of the EHR. So CHWs will recruit uncontrolled hypertensive patients using registry lists that practices have generated. So remember, the practices that we've been working with have had a year's worth of experience of running registries and identifying their uncontrolled hypertensive patient pool. Our community health workers will then deliver group and educational sessions and follow-up phone calls to these patients that are really focused on disease management. And then we've also developed a specific protocol around CHW clinical integration. And again, this is where building familiarity between the CHWs and the clinical sites has been really critical. So our CHWs will participate in clinic staff meetings. CHWs will send participant action plans and status updates to clinicians, and CHWs will meet with clinicians as needed. So I'm going to...
At this point, we do have to move on to a very brief panel discussion, but the slides will be available for everybody to see later. We will conduct a brief panel discussion, and so please use the chat feature to submit a question for any of the presenters at any time. And first, I would like to ask the presenters to discuss how public health agencies can use PRCs as a resource and form successful partnerships that reduce health disparities.
So I can start with that if you'd like. This is Nadia from NYU.
Hi, go right ahead, Nadia.
Okay. So I think what we've found is a couple of different ways that PRCs can engage with departments of health and vice versa. I think what PRCs bring to the table is that they have a deep engagement with communities as well as multi-sector partners that departments of health can leverage to both extend their reach and strengthen their own collaborations. We also develop protocols, curriculum, and tools that are really designed for real-world settings that can be used by health departments and disseminated by health departments. And then the last piece that I'll highlight is our expertise as PRCs can be leveraged by health departments for related initiatives. So as I mentioned at the beginning of my presentation, our local health department implemented a place-based community health worker model in public housing in the East Harlem neighborhood of New York. And they needed evaluation expertise as well as really protocol development expertise. And so they subcontracted directly with our PRC, and we sort of are leading the evaluation arm of that program. So it's just an example of a specific and concrete type of collaboration.
Do the other panelists have anything else to add? If not, we do have a couple of questions for all the panelists.
Why don't we go on to the questions for the panelists? I concur with everything that was just shared in terms of opportunities to work with PRCs.
Great. So this question is for all the speakers. How are you handling payment of the community health workers, and how are you able to make this a practice for the state local health departments?
Well, this is Maya with Arizona, and I'll just sort of address that. I think that the money for the research in the PRCs is relatively limited, and we work hard to get our research dollars out there so that our community partners can directly hire the CHWs and integrate them into their organizations if they're not already, if they don't already have them on staff, which most of the time they do. But I think as a PRC, it's really, we are committed to the sustainability of the workforce and looking for those kind of reimbursement mechanisms, because all the work that we do, we need to look at sustainability in the community setting. So for us, we're working collaboratively with our partners to identify reimbursement mechanisms within the clinical setting and looking at opportunities in other ways to address prevention, reimbursement for prevention in the community setting. And as we all know, it's a shifting, moving environment out there, but I think standardizing the practice by the use of a voluntary certification is one way that we're working to support the workforce on this effort. So I think our intervention is just a small piece around creating an effective intervention with CHWs, but much more broadly, I think CHWs can be very helpful in addressing the issue of sustainability.
Does anyone have anything else to add to that? If not, another question is, are there other organizations that you are collaborating with, such as your state CMS Quality Improvement Organization?
This is Nadia from NYU. I did mention that we are working with our state QI organization. They're providing a lot of the technical assistance to the practices that we're working with. We also work closely with our statewide community health worker network. And just going back to Maya's point, that really helps to contribute to sustainability of the CHW model, as well as promoting the CHW workforce more systematically across the state and through our research project.
And this is Jennifer. We're collaborating also with our Area Health Education Centers program to assist with providing practice facilitation and also working with our statewide task force.
Great. Thank you so much.
This is Maya, and I just also mentioned that we're very committed to working with the tribal entities that are in our state.
Mm-hmm.
Wonderful to hear. Have you been able to demonstrate a reduction in healthcare utilization and cost as a result of community health worker interventions?
So I think that this is Maya in Arizona, and as we put together our advocacy kit around community health workers, we really have scanned literature, and there is evidence out there, particularly from New Mexico, specifically about the cost effectiveness. So it may be worthwhile to share those particular publications. There's also evidence that community health workers save money in maternal and child health, as well as in asthma care. So there's a lot of evidence about the effectiveness of the model, less so in terms of financial gain, only because it hasn't been done yet. There's not evidence that it's not effective. So it's just a matter of making sure that you get pointed to those resources, because there's substantial evidence around cost effectiveness in community health workers.
And I'll just add, this is Nadia from NYU, that a key reason for us to partner with a payer organization, Health First, was to be able to have access to claims data so that we could eventually answer those types of questions.
Great. Thank you so much all for joining us. Do you have anything else to add about PRC partnerships or any last thoughts?
I'd just like to thank ASJA for the opportunity, and to our health department colleagues across the country. Just really encourage you to think about the PRCs as a resource in conducting community-engaged research.
Great. Thank you so much for joining us today. I would like to thank the CDC for sponsoring this webinar. Please fill out an evaluation at the conclusion of today's webinar, since this evaluation will provide us with useful information for the future webinar series. Thank you so much, and enjoy the rest of your day.